The idea of setting up think tank in Western India was the idea of a present Prime Minister with his Chief Minister of Gujarat. He felt that all the think tanks are based out of Delhi, and therefore we should get a more regional perspective. Regional does not mean against the national perspective, but adding flavor to the national perspective. Our focus area is public policy, policy research, and international affairs. Things associated with Mr. Vajpayee, and therefore his. We have now started a series of talks, webinars, and every Friday. Every alternate Friday is either public policy. Right now we are concentrating on economic governance. It's what we're going to do today. And every alternate Friday we have international affairs. And all of you who are here today and will join us later on, we'll put you in the mailing list to keep you informed. We hope you'll keep joining us again and again. We know that there's lots happening, but I thought that topics like economic situation does bother all of us. It does bother all of us. And to that extent, we thought that we should bring all these issues of the economic situation right in front, so all of us are aware. We're lucky to have Dr. Shamika Ravi speaking today on us. She has many, many laurels. I won't even go into her CV. PhD from New York, other studies from here, lots of publications associated with lots of Indian academic listings, and lots of fellowships and visitors, etc. So she brings with us tremendous amount of knowledge. She was also associated with the Prime Minister's Economic Advisory Council till last year. She brings a richness of experience, and she's been writing and speaking on these subjects for a very long time. So we thought we'll request Dr. Shamika Ravi to kick off our first on the economic governance. We'll have a series, as I said, every series. I'm also lucky today, we are also lucky today that Dipankar Sengupta, Professor of Economics from the University of Jammu, is here with us today. I hope at a later stage he'll also speak and be associated with the institute. He's done also some very interesting work, say comparing the public investments in Jammu Kashmir and Himachal and see the different outcomes. So we thought we'd bring subjects like this to bring it to a harnessing. Let me not take more time. As I said, my connection is very unstable, where you can still hear me. I wanted to speak. I would request Dipankar to take over now, speak for a couple of minutes, and then request Dr. Ravi to speak. I think Dr. Ravi will speak for about 20-25 minutes, and then open it up to questions.
I think it's pointless to introduce Dr. Shamika Ravi. Her CV speaks for herself. She is Research Director, Brookings India. She has been in the Prime Minister's Economic Advisory Council. But very importantly for us, and particularly important today, she has been one of the few economists who has tried to educate the public on social media, and her tweets on social media, particularly COVID updates, the manner they are put across with the help of charts, etc., helps to bust many shibboleths, many myths. And I, for one, have been extremely rich in this fact, because what I do is to take the graphs from Twitter and put it on my Facebook, where I get a lot of likes. Now, what Dr. Shamika Ravi will speak on today is COVID-19 and its impact on the real economy. Now, we've already had a first round of debates when the first wave of COVID was going on. Now, the second wave of COVID seems to be receding. And that also has basically put in a new dynamic, because it has raised new uncertainties into the equation, and we don't know how this will play out. So in this regard, Dr. Shamika Ravi, who has always spoken to us on this particular subject, I request her to speak for about 20 to 25 minutes, after which I'll do some sort of a summing up, if at all such summing up is required, and then we'll throw it open to the public. Dr. Shamika, can you start, please? The floor is all yours.
Sure. Thank you very much. Namaskar. Good afternoon, everyone. It's always a great pleasure to be, connected virtually. Of course, this is an entirely brand new world, but it also gives us this opportunity to talk quite frequently, I think, while physically it was, I suppose, not as feasible. But Shakti, I laud your effort. I think it's great to move some of these discussions. Of course, it's all virtual now, but I think in the physical sense and in terms of building capacity, it's very important to get out of Delhi. And I'm going to talk a little bit about why the perspective out of Delhi is very important as far as the economy as a whole is concerned. Now, let me see if do you all see my slides?
Yes, we do. Yes, we do.
Okay, fantastic. So my slides are really just data points, they're pictures. They are all part of larger research. There are several other papers which are out there. Some of them are actually which have just come out. Some are going to come out in the future. But what I'm going to give you are just evidence. It's just data, and I'm going to tell you a story through it in terms of what the status of India's real economy looks like. Now, the reason I think it's important to focus on the real economy, and so what is economy vis-a-vis the real economy? The reason I talk about the real economy frequently is that, the economic discussion, the dialogue in Indian policy making, and I think generally, in the public debate as far as economy is concerned, it really remains restricted to a few macro indicators. And that is really quite unfortunate because, the real economy is beyond inflation, the fiscal deficit, and a couple of broad indicators. So we are really going to talk about the real economy, which has to do with labor market, which has to do with variations. It's a very large country. So what are the variations across these 28 vibrant state economies? And of course, the health sector, which I think is the pivot from which we have to really see a growth potential over the next few years. Let me start out by first giving you a sense of where we are today. Well, this is the overall picture. As you can see, we've had a huge second wave. But we, as of now, we know that we have close to 30 million confirmed cases, which is a very large number. Of course, a very large percent of this naturally have recovered. But the reason I think the public debate on recovery gets misplaced because I think from the government side, recovery is shown as a great mark of success. But in the media, I think recovery is often discounted as something natural. Of course, a very small percentage of people are meant to die from a disease like this. So why do we talk about recovery? Well, recovery is important because it gives you a sense of what is the fraction of population, how many people are out there who have naturally gotten infected from this virus and therefore should be carrying antibodies. Okay, so in some sense, they have been vaccinated. Now, that is where the duration, the decay of antibodies and the frequent seroprevalence surveys become important. So this is as of now what the picture looks like as far as confirmed cases are concerned. This is the scary picture that we all see. And now this graph, I think, has become very popular. You see this everywhere. But it just tells you how sudden and how massive the second wave of infections in India was. I think the country's gone through sort of a huge trauma if you consider just the suddenness and the gravity in terms of the number of lives lost. And we do know there are, of course, reporting errors. I'll talk about the data as well and how the truth always lies in between. I think what the government tells you, because there's time that the government requires in order to put some of the stats together, and the capacity, and what I think the bottom-up media, I think there is stellar ground reporting happening from many parts of the country, and yet the level of let's say the number of deaths or what is being, I think there is over reading too much into the data and trying to portray an image, so there's overfitting of the model. Sometimes we say in economics, I think there's some amount of that happening, and it's important to understand why the reality is somewhere in between. But the second wave was very bad. And this is a graph just to tell you, the black graph at the bottom is the first wave. And I'm marking the waves by the number of days, how bad things were and for how many days we remained closed and indoors and economic activity was low. The second wave is this orange graph. And it just tells you that, within 80 days, we were hitting, close to 4 lakh cases a day. I mean, this is not news to you, but the difference between the black and the golden or the orange graph tells you the difference in the magnitude. This is massive, right? This is enormous. And of course, now we know from the genome mapping data that a lot of it had to do with this Delta variant, which we know is far more transmissible. Right now, the UK, after considerable success in their subsequent waves, is as of now currently reporting around 11,000 cases a day, and largely thanks to the Delta variant. So these are new beasts, and a large part of managing the COVID situation and the economy in the COVID has to do with staying ahead of the virus. So the genome mapping, the seroprevalence surveys, and of course the vaccination drive are a very large part of this bigger puzzle we are trying to solve as far as the real economy is concerned. Now, we are now almost heading close to what the first wave was, which is manageable from the perspective of health infrastructure. But these are just cases. I think it's important to remember that in terms of deaths, India is still reporting around 3,000 deaths. These are 7-day moving averages. So it's not day-to-day fluctuations. These are slightly longer term trends. So as of now, we're still reporting close to 3,000 deaths a day. Now, a lot of states, and I think this is an important message that everyone must understand, that our state capacity for data gathering and data dissemination is very, very limited. I think the pandemic has also come as a rude awakening to how limited our real-time data gathering and dissemination capabilities are. Now, you know, for the first many decades, I think India did put in a lot of effort as far as NSSO, ASI. We have been pioneers as far as surveys are concerned. And we do have a basic architecture of data gathering and quality data gathering. A lot of global knowledge in terms of development has been furthered on account of public data from India. But what is happening now is that the economy is moving very fast. We are a young but a very dynamic economy. It is very difficult. It's very inefficient for an economy as large and fast moving as India to have a census every 10 years, now likely 12 years, to have employment data collected every 5 years. So you see, what worked in the beginning for many decades is just not going to work anymore. And I think that is where you are seeing an attempt by the government to bring in new data systems. And I think that is where the gap still remains, because the needs are exploding. And I think the government capacity as far as data collection, analyzing, and dissemination is concerned is unfortunately very limited. Now, if this is the situation at the center, you can't begin to realize what the situation in many of our states are concerned, because a lot of data, including the death data, which is becoming such a big cause of debate, is on account of a state gathering this data and putting together. Now, death registration in India has always been very, very, it's fluctuated a great deal, and it has always been quite limited, barring a few states, including, frankly, some of our more developed in terms of health, public health, Tamil Nadu and Kerala. Even there, death registration is not very high. In UP, our death registrations are in the 30s, right? So it's quite limited. But I think that is not the only issue. The other concern is that our death registrations have typically fluctuated so much year on year that, just to give you an example, in 2017 or 16-17, Nagaland had reported almost 90% of its deaths. And I think by 18, you saw only 9% of deaths registered. So these large fluctuations are also on account of, I think, state capacity to collect public data and put it together. So I think it's important now to get into the details of how limited India's civil registration vital statistics or sample registration surveys, etc., are concerned. And I think this rude awakening is important. I think it's a very enormous, it's a big, significant cause. And I think we should rise to the occasion and try to meet those expectations. But if, there are many people who believe the numbers are coming down only because we aren't testing enough, that's not true at all now. In fact, our testing per million has shown several inflection. It has really been scaled up. And if you see the test positivity rate, that's the bottom black graph, you're seeing that, we did have inadequate testing in the beginning, but over time we've picked up, including in the second wave. So now the decline in numbers is, and which is often the case with India, it's always, you're talking about a continent. So it would be as really as talking about all of Europe and not getting into the details of different countries. And it is the exact analogy you must apply when you're talking about COVID in India, because the states are undergoing very different realities because they have very different state capacities and the nature of the virus, the degree of urbanization. And now, of course, the genome mapping is telling us that the variants present in different parts of the country are also likely to be very different. But what you're seeing at the national level, this decline in terms of daily cases, is happening everywhere in the country. So clearly, India is over its enormous traumatic second wave, and in every part of the country. But if you look at the death, I think the case fatality rate, even if there is noise in the data, because the registration of deaths is very different across different states, I think it's important to see the long-term trends. And you're seeing that, at an all India level, and you see India at the right-hand side column, the second row, that is the all India average. You're seeing, and this is a global data, that with time, fatality rate, meaning deaths per 100 cases, have been falling. So this is a global phenomenon. And we have seen this at the all India level. But if you begin to look at separate states, then largely it does seem to be the case with most states. But there are states where with time, deaths per 100 cases have actually risen significantly. Of course, Punjab still is reporting the highest fatality rate in the country, followed by Uttarakhand, Maharashtra, Delhi, etc. But look at Jharkhand. Deaths have actually risen with time. Look at Chhattisgarh. Deaths have risen with time. Bihar, huge number of deaths in the second wave. More importantly, these are big states. If you look at the small states, and I think this is what the larger media and the public discourse in India misses, that India does not sit in Delhi. India does not sit in national averages. A lot of the insights are lost because we're not parsing out these details. Look at Nagaland, Goa, Meghalaya, Andaman, Nicobar, look at Puducherry, look at Sikkim, Manipur, all these small, Tripura, Lakshadweep, they have all seen a huge jump in fatality rates with time. And this really goes against, it flies in the face of the hypothesis that with time we understand the virus better. We have more capabilities because we've had time to build those capabilities, right? Whether it is masks, it is the PPE suits, it is beds, it is oxygen cylinders, whatever. With time, you have means and opportunity to build the infrastructure or the requirements. But clearly, in most of our small states, some of our big states, we're not seeing this. And this, I think, is a huge debate for policy. It's a concern. I think we should discuss this. That why is it that we are not improving with time? And this is not just on account of the second wave. This takes us to the vaccination drive. Now, remember, vaccination is, I think, the priority number one as far as reopening of the economy is concerned. Now, we don't have a national level lockdown, and you'll see that in a minute, that people are responding to local conditions. But vaccination drive is really the sort of the bulwark or the cornerstone of how long-term economic growth strategies will unfold. And India's growth will be determined by the pace of the vaccination drive. Now, overall, of course, we are seeing that total numbers are increasing. But what's very important to see that in the beginning it was slow, but then it scaled up really fast, and then we sort of paced down again. If you see the total, and you see a male, female sort of a difference varying, but India is also a pioneer on many accounts. I think we are one of the few countries that has data on third gender vaccination. And I think these are small institutional characters which I think are important to emphasize. Now, if you look at dosage, first dose is, of course, rising very fast, but ever since we have introduced the policy of increasing the space between the doses, look what's happening to the second dose. Second dose is really flattened. And I think this debate is beginning to get reignited on account of the fact that the Delta variant is far more transmissible. And it is only people with double dose who are really protected against severe infection or hospitalization, etc. So I think this is still an open debate, and I think likely to be a matter of discussion within the government. Of course, the long-term, the supply, the logistics of supply chain of vaccination is, I think, one of the bottlenecks right now. But gradually it is getting relaxed, and this is how you see it. This is the average growth rate. So this is the speed at which we are vaccinating people. It really increased in the beginning fast because, when you start from a low growth, low base, you rise very fast. And then, and it rose all the way till 45-year-olds were, it was open to 45-year-olds. And after that, it really fell. But thankfully, in the last month or so, it has begun to pick up again. And that pickup is gradual, but it is sustained. And thank God. But there are huge variations across states. Despite having vaccinated over 2 crore people, Uttar Pradesh has only about 14% of the eligible population, which has received 1 dose. Compare that to Himachal, where more than 40% of the population has received a dose. So there is a big variation within the country. I think it's also important to recognize that equity is a concern, and I think equity is a very large concern when it comes to an open democracy like ours. But I think we have to have serious discussions on efficiency, meaning what might be the smart strategy rather than spreading ourselves thin. You can see that there are states which have very low vaccination rates, including, let's say, Tamil Nadu, Jharkhand. And these are not on account of shortage in supplies. There is serious vaccine hesitancy in many parts of the country. And I will go within states to specific districts. But look at Tamil Nadu and Kerala. They are at the two ends of the spectrum. I mean, these are neighbors with very similar public health infrastructure, quite good. There is considerable literacy. So when people say it's illiteracy or lack of awareness, which is leading to hesitancy, I think that's a bit simplistic, which means that many of these states, and health is a state subject, but perhaps with a push from the center, many states have to now start initiating drives against this vaccine hesitancy. This is not new. We've done this in the past, particularly, I think, when it concerned a certain vaccination for children in the Muslim community, Shabanas. I mean, lots of movie stars were mobilized to build trust. I think we have to go back and revisit some of these issues. But quite surprising when you look at Jammu Kashmir, Uttarakhand, Kerala, these states are doing quite well. These are the percentages of people who have received, they're fully vaccinated. And you see that Delhi's 10% of its eligible population is fully vaccinated. It's the highest in the country, followed by Gujarat. UP, again, is less than 3% and a long way to go. In real sense, there are also other concerns that there is a huge gender disparity. It is not something we can brush aside. Look at the gender disparity in Jammu Kashmir. Look at the gender disparity in Delhi. Now, this also, in some sense, mimics our gender literature when we do find sex ratio discrimination, in some of the most affluent parts of the country. But Delhi's gender ratio, if you look at the vaccination, you do see that there's a significant gap between men and women as far as vaccination is concerned within a state, and this is UP. Look at Noida, that's Gautam Budh Nagar, Bagpat, Lucknow, Meerut, Ghaziabad, cities, right? Cities are getting vaccinated very fast, not just because they receive more vaccines, but there is a greater demand for vaccine, right? As against a lot of the rural districts. Look at Raebareli. Raebareli has not moved from the bottom 3-4 districts in the country over the last several months. These districts are really lagging behind, again, not on account of shortage, but we do know that lots of camps are being held. Asha workers are going knocking on doors, trying to pull people into camps, huge hesitancy. So many places where the vaccination drive is likely to remain laggard or slow. The economic recovery, the way we think about it and talk about it from Delhi, I doubt if we're going to see a similar pace of movement of people. There is considerable fear of the vaccine as well. It's not just UP. Look at Tamil Nadu. Tamil Nadu also, the Chennai, Nilgiris, Coimbatore, very high percentage of vaccination. But again, if you go to Tiruvallur, if you go to Tiruvannamalai, these are all very, very low. So variations, the urban-rural variations are real within a state as well. This takes us to now the GDP. What is happening in this larger context that there is a huge second wave that has happened and we are sitting with a very low vaccination coverage as of now? Well, we are one of the few countries that had relatively, if you look at deaths per million, fewer, but the economic cost of that has been very severe, right? On the right-hand side bunch, you are seeing countries which have had many deaths and loss to GDP. But on the left-hand side, you are seeing countries with relatively fewer deaths, but India's towards the top end, which means the economic loss, despite having fewer deaths, and of course, this is per million. We are a very large country, so in terms of per million, the deaths sort of get dwarfed. but the economic cost has been huge. And this is mimicked even in terms of economic mobility of people, recovery. Just, the black line you are seeing here, this is movement of people for recreation, retail. And this is one of the best proxies for economic recovery because GDP data takes time to capture. We get it every quarter, etc. And again, there is noise, the way we are capturing some of that. This is day-to-day data. This is people actually, this is Google mobility, people's moving around. And you saw what happened in beginning in March when all countries went into lockdown, huge decline in economic activity. But after that, most European countries picked up very fast because they were actually very quick to open. We opened, we had several phases of unlocking. So we were very slow. We are really one of the slowest in terms of opening, but we were steady because that's when a lot of the European countries had a big second wave. And you see again, economic activity decline. India stayed steady, except what you're seeing is as of middle of March, when economic activity in India began to really crash on account of the huge second wave. We've had a pickup in the last 1 month. So the economic activity is also beginning to pick up. What you're seeing at the national level is mimicked across states as well. Now, for the discernible eyes, you'll see that people's mobility declined significantly before states actually imposed lockdowns. So I think people are responding to the infection. People are responding because there's fear. There is shortage. There is shortage and the infection is scary. It is still an unknown beast. So people responded in terms of lowering their mobility even before states went into lockdown, a good 2 to 3 weeks before official lockdowns were imposed, in some places even a month. So people are responding. State governments are a little slow in responding. And of course, in terms of Delhi, remember we were still debating. We had 20,000 plus cases, whether to go into an unlockdown. And of course, when we have fewer cases today, the unlocking process is still a matter of debate. But people are responding to the virus and the actual infections, not just the policy changes in terms of lockdown and unlockdown by the state. These are the IMF forecasts. Remember, we were supposed to be the fastest growing country with 11.5% projection for next year. But as the IMF a few weeks back has come out and said, look, because the second wave was so deadly and it has really put economic activity in India under bind and it has slowed us considerably, they are going to revise these estimates, right? But we have to wait and see what the next set of estimates are. In the meantime, of course, we have had all these different kinds of reforms announced, particularly the property documents, the land documents, the property card, the labor market reforms that various states have introduced. And agriculture, of course, the bill is still a matter of politics, but in several states, it has already come into play. How does that get reflected in terms of actual GDP per capita? Well, steadily, we are seeing that GDP per capita in India is on this steady path. And it is mimicked by improvements in human development indicators as well. Meaning we have not strayed away from the long-term path of growth. And I'm not talking annual growth. Of course, annual growth now is much lower than it was. But if you just look at GDP per capita, there is a steady path. We are not on an inflection path. Of course, we talk about exponential growth. We are not in that phase. We haven't been for quite some time now. But in the long-term path that we have, we are still steady on that. In terms of human development indicators, India is about 10 years behind China. This is now open to empirical research. That what has the pandemic done to health, education? It has been a huge shock, gender, etc. So let's see if we have fallen off this path and by how much. Connectivity remains very, very high. Because we are in this pandemic, it's very important for me to tell you that in terms of the real economy, India's health sector looks very different in different states. In states like Odisha, Kerala, Jammu Kashmir, Himachal and all, Tamil Nadu, the public health system actually works pretty well. So you will see people across quintile groups actually going to district hospitals and the government hospitals for care, primary health centers, etc. Very small percentage depend on the private care. But UP, Bihar, Jharkhand, Punjab, Telangana, not just poor, remember, also rich states, Punjab, Haryana, Telangana, fast-growing states. Very large percentage of the population depends on private healthcare because the public healthcare really isn't very good. This has very different implications for long-term sustainability of Ayushman Bharat or universal health coverage. But in the short term, just know that because COVID is an infectious disease, the burden of any infectious disease, disproportionately falls on public healthcare. Because private hospitals always have a problem with large infectious diseases. They are able to price and perform well in markets where diseases are idiosyncratic. So lifestyle diseases, diabetes, heart, etc., cardiovascular. But when it comes to large infectious diseases, then really the role is that of the government sector. So again, the performance of the state, the dependence on the public versus private, and people's experience with what COVID has been is also determined by this variation, the strength of the public health infrastructure, and in places or the lack of it. Right? So it's important to keep that in mind. States have very different growth agendas. They have had very different experience as far as 20 years of growth. That is also going to impact future growth. But this is just to tell you that India has states have had very divergent. There has been a lifting of the tide, but there are breakout states and then there are states that are falling back. Okay, so this is also likely to be the case post-COVID. But at the end, the reason we all keep talking about growth and why growth is important, because it's not about millionaires list and billionaires list. It's about how many people we can pull out of poverty. We had broken certain records, and we are now no longer the country with the largest number of absolute poor. We had fallen below Nigeria, Congo, which are substantially slower countries, but it's on the back of economic growth that we were able to pull people out of poverty, and hence the discussion has to go back to growth. This is important because this is telling you how has consumption changed across different quintile groups because of COVID. Top 20% to the bottom 20%. COVID has led to decline in consumption for all consumption groups. So all classes of people have lowered their consumption. In the beginning, the rich won. The top 20% really did not. In fact, they had a slight increase if you look at April, May, June. Subsequently, as the pandemic deepened economic recovery was slow, you are seeing that the bottom 80%, so the middle class has suffered an equivalent decline in consumption as the poor, so as the bottom 20%. And I think this becomes very important from the point of view of what kind of consumption support the government is planning to give out. So from a fiscal support or a consumption support perspective, so far we've heard the government make announcements as far as food distribution, cash transfers, etc. are concerned. They have largely been focused on the poorest. And I think it's important now to spread that, to sort of open that more, to include the middle class, particularly as far as the PDS, food distribution, etc. are concerned, because consumption has fallen quite comprehensively and will need some support. What about inequality? Well, if you just look at the share of different quintiles, then the share of the bottom three quintiles, so the poorest share have fallen while the share of the richest has increased. So inequality has therefore worsened. But I think right now it is not as much inequality, which is a concern, as absolute decline in consumption. This takes me to another large policy debate, and we just had a group of doctors, experts come out yesterday saying the government must extend cash support. Now, cash in the hands, food grains and certain essentials, cash support is important, but widespread cash distribution in the form of a UBI or is unlikely to translate into rising consumption or rising demand, because at a time like this, there is widespread uncertainty. There is a lot of fear. And under these situations, when you give cash to people, they are more likely to, save it. And we call it precautionary savings. You're only going to consume what is basic minimum. So cash will really not be helpful as far as raising suppressed demand in the country. And there are, of course, and I can talk about it in the Q&A. Instead of direct cash transfers, I think the government should think of other forms of fiscal push. But of course, to the group, which is the bottommost and middle class consumption support, are important. I think they have to go beyond what is being currently given. Now, we do have a plan of economic recovery, right? If you go back to the budget speech of this year, just a few months back, I think there was a very clear line of thought. We are thinking of pulling out of this, the economy out of this hole through massive infrastructure spending. That was what the FM's vision is, and I think it's a good vision. At a time like this, when private demand is unlikely to go up, private consumption is unlikely to go up, private spending is not going to go up because there's so much fear and uncertainty. The task is therefore of the government to raise spending and to spend. And it's best spent on productivity enhancing investments like infrastructure. And health is a part of that. But we have also heard, I mean, the speech was very clear in terms of how are we going to finance that spending. And in the speech, privatization, divestment, disinvestment, give it any name, but that was a very major part of this strategy. So I think on that account, we have to now start putting our mouth where, cash where our mouth is. So I think there is a strategy to come out of this. I think the implementation now has to be such that these become credible, across states, across industries. Some industries will need a lot more hand-holding. But with receding numbers in the infection, the cases, I think economic recovery, mobility of people, they've all begun to pick up. So I think now green shoots, and it's a tried term, I think economists use it too often. But I do think the recovery path, we are gradually getting onto that. Thank you very much.
Thank you very much, Dr. Ravi. A marvelously educative and analytical lecture again puts a lot of ideas into our heads. Let me just give a few takeaways. I mean, what you've brought out is the massive variation in data. I mean, there is some data that public sees because it's made available by the Press and Information Bureau and the press. And the wide variation in data when you look at the state level, so that if we think we are understanding the virus, we are sadly and badly mistaken. Number one. Number two, the disparity between the urban and the rural areas, the various states, and so on and so forth, variations in public expenditure, the havoc it has played with the consumption patterns, and that's changed. It's no longer just the poor which have held back consumption. It's now the middle class which is holding back consumption, which is, of course, impact on aggregate demand. And the question that you asked, very rightly so, what does it do to our plan of spending our way out of trouble? And spending meaning spending in public investment out of trouble. These are the questions that we ask. The thing is that plan still there? Even if that plan is still there, will it work now? Given the added uncertainties that wave 2 has put in. I think this is enough to, set the ball rolling. I would ask people to use the chat box as liberally as possible. It may not be possible for us to, give everybody time to ask questions. So the floor is, of course, open to all of us. Anybody who wishes to ask a question, no comments right now, please, is free to ask. Do we have any questions? I think I see Smita Sharma putting up a hand. Please go ahead.
Hi, Shamika. Good to see you. Just two quick questions. One, on your data on the rural sort of dip when it comes to vaccination strategies. You did mention vaccine hesitancy as being a reason, but also how much of the digital haves and have-nots divide sort of worked towards it, because it's only now that certain vaccination drives of door-to-door campaigns are happening, but the COVID registration process itself seemed to be a major hurdle. And B, your estimations really, because we have a very ambitious government claim lying in court of vaccinating the country by December 2021, notwithstanding your own data estimations of when you what's the kind of vaccination percentage, the vaccination numbers that we need to see on a daily basis to say achieve a 50 to 60%, which then definitely gives the economy a spring to spring up from. Thank you.
Answer that, Shamika. Yeah.
Sure. So, Smita, Absolutely valid concerns. I think on the rural-urban divide, Smita, I don't think it was COVID which was a problem. Simply because in the rural areas, you see, and I think even in many of the urban areas, the registration of people on COVID was happening when you went to get vaccinated. There was somebody also entering your data. Now, but we have seen this in the cities because people would only go if they had a confirmed date for vaccination. There were glitches. I think, I don't know what the situation is now, but in the beginning there were glitches. People were finding it difficult to get slots, etc., and nearby and so on. But I'll tell you, there is increasing evidence of people moving to rural areas in the neighborhood of cities simply because it is easier to get the vaccine there. Increasingly, I'm surprised how many of my own students, and I'm teaching, and I hear that they are going out, and this is across. They're going to Haryana, they're going to places in UP and getting vaccinated. And when they go there, they show the Aadhaar and the COVID happens. So I think COVID is a concern because it is still one additional layer of requirement. In the past, we have never really depended on technology. Technology makes things more tractable. And I think that is where when you're trying to manage such large-scale logistic exercise, which is not the supply of the vaccine, but also the back end, every support, refrigeration, people, so on and so forth. I think then managing it through COVID is very appealing. But on account of the fact that in the past we've had successful vaccination drive and we've never really needed to register, could also mean that if COVID is a problem, let it be handled ex post. Let that registration, you collect the Aadhaar digit and then you put it on COVID later, if that is indeed but I think I'll tell you one thing, the states are innovating, Smita. I'm hearing such different experiences of citizens across different states that I think just curating that would be a very good exercise. The second, the issue, what you said, we are right now around 22% vaccination of all eligible people. Eligible population meaning 18 plus. We are around
a single dose or a double dose that you
single dose. Now the problem is that this is then just math. With math, we can just say, okay, if this is the pace you're doing. But I'll tell you, it's a futile exercise because our constraint is really a supply constraint. It fundamentally depends on when can we bring in the next tranches of what is the pipeline of doses, right? So I think eventually more clarity on that in terms of what is the manufacturing capacity enhancement, that will determine what is the pace. Because I think at the peak, we were hitting almost 45 lakh a day. We were vaccinating at a very high pace in the beginning. And then, of course, on account of wider distribution and sort of a supply bottleneck, it came down. Now, again, it has picked up. But this is clearly not sufficient. I think we can vaccinate many more people every day. But I think vaccines, the shortage is a problem. And I think another issue, which is politically, it's a seminar, so we can have this discussion, but I don't know how palatable it is. We should have a discussion on equity versus efficiency. There are lots of vaccines and vials lying underused in a lot of rural areas. At the same time, we have lots of people waiting and not getting a date in the cities. So I think, pushing equity for equity's sake, I think large federal countries, we must be open to having that discussion, perhaps at a state level, right? Even within a state, can we have this discussion that, look, if people in Rai Bareli they don't open the vials because they can't get 10 confirmed cases. So it is either going to end in wastage, because once you open a bottle, you have to vaccinate at least 8 to 10 people. Or you don't register, you're waiting for the 10 people to show up. You just keep waiting, hesitancy. So I think these are debates at the local level. We can't have, but at least theoretically, we must ask these questions. Equity for equity's sake, is it really the best way to handle a situation like this? Yeah.
I thought I saw Mr. Gautam Sen trying to ask a question. Yeah, please unmute yourself first. You are muted.
Thank you, Professor Sengupta. You see, my point was, it was a very enriching lecture by Dr. Ravi. Incidentally, she mentioned about variation of death data in a state like Nagaland, where I happened to serve as an advisor to the government quite a few years ago. Now, the essence of the matter is that, in the tiers of governance, particularly in the second and the third tier of governance, there's a lot of dissonance. So that has to be overcome. On that, I think if she could dwell a little bit, and then the problems of equity and other things would gradually fall in place. That is the point I wanted to make. Thank you.
Thank you. I think, this is a much more nuanced point, which our larger public debate on data is missing. And I think it is on account of that this larger narrative that, look, India is basically hiding data. The governments, all governments are hiding data. We just don't want to tell what the number of deaths are. Now, first thing is that, all-cause mortality or excess deaths, what is a common now calculation and everyone is doing, it makes sense in the richer OECD countries, where they have good systems of data collection. So year on year, when you compare that, look, we can't attribute this to COVID because it doesn't say COVID in the system, but because there are so many excess deaths this year, we can largely attribute all of this to COVID. It works in a place where data collection, or at least data systems, just the way they collect regular data, good CRVS, if that is robust, then excess death makes sense. But in India, remember in the beginning also this exercise had started, March, April. And then we saw that on account of the fact that we were losing fewer, at least 2 lakh fewer lives to road accidents, meant COVID is a very good thing in India because excess deaths are actually falling. You see, excess death makes very good sense in countries where they have good data collection and they can actually attribute causes. Here it is a huge problem. You could actually be overfitting and very simplistic in trying to measure. What Dr. Sen's question, it's a very good one, and I'm very happy to hear that you worked in Nagaland. But sir, I don't know how happy you will be if you know that IIT theses are being written on poor nature of public statistics from Nagaland. In fact, there is an IIT professor, he's written a fantastic book from the Cambridge University Press on statistics and data at the periphery of the country, and Nagaland is his case study. That in 1 year Nagaland had 90% death registration. In the next year it had 9% death registration. Does that mean, what does that even tell you? That perhaps data collection is not really high priority. It is, the state capacity for data collection is not as robust everywhere as we'd like it to be. And frankly, that is the problem today. But in no way should we say it is okay. If anything, this is the wake-up call perhaps we need to move the country ahead to real-time census collection, to a robust civil registration of vital statistics. It's 12 years, we don't know what the population of the country is because census has not happened yet. So I think data now, we keep saying data is oil or whatever those trite, but data is just, oil is only useful if you can process and make some sense out of it. No, data is similar.
Yeah. Achha, before we carry on, just one question to what Smita said. You talked about supply being a constant, supply of vaccines being a constant to our vaccination efforts. But suppose I want to scale it up to 10 million jabs per day. Do we have the nurses to deliver these jabs? Is it just a vaccine constant? Because I think somewhere down the line, there'll be a trained manpower constant also. Number one. The other one, slightly more controversial, you talked about efficiency versus equity. Let's go beyond this. Suppose as a matter of strategy, I know that the hotspots are urban areas because people live in close proximity. So forget about efficiency. Strategy would demand that I do the hotspots first before I move on to the rural areas. Is that something that we should consider, at least at the state level?
Absolutely, Dipankar. Absolutely. In fact, this is something we had been talking about, right? We still, remember, for us, it's not like we said we talked about it and we didn't do it. We can still do it because for us, the problem is one of the next few years. What should be the strategy? And I think that is what I'm trying to say, that instead of flooding, trying to say equity everywhere, every district will get a proportion of its eligible population, we will keep supplying it. You see, that is the simplest headcount way of distributing vaccines. But the fact of the matter is, this virus, now of course it has spread to rural areas. But for the longest time, and perhaps still now, it remains an urban phenomenon, largely an urban phenomenon. But Dipankar, it's one thing for you and me to talk about it. The political economy of it, the politics of it, not going to be easy. Can you imagine any state, any politician, any bureaucrat saying, you know, the risks are higher and therefore we will give it to the city guys? And also remember, voting is better in rural areas.
Do we have the nurses to deliver the jabs if you want to go 10 billion?
Good question. Now, human resource is our most binding constraint on all counts of health. Right? On all counts, we have, you know, the lowest number of doctors, lowest per lakh, let's say, ANMs, nurses, etc. And the reason it is most binding is it is inelastic supply. You see, even in UP, we have many districts where we have required number of community health centers, wellness centers. They have all been built because it's real estate. Real estate is the simplest thing to build in India today. You give them land and you give them, it'll get built. We also have the best equipments. In fact, if you go to district hospital, medical college in Kannauj, one of the poorest districts in UP, you know, huge radiation equipments, I mean, radiology equipments, very expensive equipments gathering dust because the doctors aren't there, the nurses aren't there. So generally in healthcare, what you're saying is the biggest constraint, human resource. But the vaccination drive is not only on account of that. In fact, the binding constraint is production capacity constraint there. Because we do have, remember, we have given 50 lakh jabs a day. We've had those experiences. So we can do it. The fact that we are doing 35 or we were down to 20 lakh is not on account of human resource. You're on mute.
I think there are some questions in the chat box you may like to address meanwhile, Shamika.
Yeah.
Sorry, because Dipankar has not unmuted himself, so I'm just...
Yeah. I'm trying to get to the... Yeah.
Karishma has a question on gender inequality.
Karishma, can you ask, please? Because I don't have access to. I think I might have closed it and I don't know how to open it.
Yeah.
Please.
Yes, ma'am, my question is that gender inequality in our vaccination coverage brings to light the discrimination and the barriers which are faced by a third gender. So what steps the authorities and officials should take to include them in the medical aid and reach them out for vaccination?
A good question, and it's a huge concern, Karishma. It also reflects the larger inequity in healthcare in any case. Just to increase your fear or appreciation of the problem a bit more, let me tell you that, you know, in a place like AIMS in Delhi, good care of you, whether you're male or female. It doesn't give differential pricing, male, female, you know, similar prices, etc. The society is very discriminatory, meaning we have estimated that 40% of female patients are missing in AIMS. Meaning AIMS should have had, if society treated people equally, this is removing all obstetrics and gynecology related problems, there should have been at least 60% more, 40% more women coming into AIMS. So these are discriminatory practices in the society. Under normal circumstances, we can say, okay, it's a society, so we'll have to worry about policy interventions of that nature. But as far as this infectious disease and therefore vaccination is concerned, there are huge externalities. Imagine a household where the men are vaccinated and the women aren't all vaccinated. The fear of threat, the threat of infection and whatever shock the household is likely to have, that still remains, right? And we don't know what future variants, etc., are likely to be. So I think, given the nature of the infectious diseases, there must be drives. That is the best you can do. There have to be large public drives to get women out, and perhaps sometimes, once we've covered some core minimum, make it more accessible. Go down to the wellness centers and the local community health centers to make vaccination relatively more easily available.
Thank you, ma'am.
Okay, there is a particular question on, I want to ask, as the price of oil is rising, it will put more pressure on consumption patterns of people. I don't think it refers, let's ignore this particular question. One thing that you talked about is that the middle class also needs help. Okay, where the poor was concerned, I think the jam trinity in a sense delivered, and you use the public distribution system. What help can the government conceivably give to the middle class?
Pankaj, middle class can also do well with PDS. You see, middle class we are defining quite loosely right now. If you just look at the weekly consumption expenditure, then these are small amounts of money. Right? We are seeing 30-35% decline, which means they are substantial decline. But barring the top 20%, you see increasing the PDS to so the top 20%, we know that PDS is not the best way to support the consumption. Perhaps think of tax breaks, etc. I think GST, seriously must consider sort of counter-cyclical sort of measures to this decline in consumption. I think it's very important to think about it. But for the bottom 60%, having consistently 35% decline in consumption, food is a very large part of it. And remember, recently now we've also started getting a little bit concerned about inflation and food inflation, etc. So we shouldn't discount PDS. PDS is not only for the poor. Now, or perhaps bring some essentials into it, right? The one thing we haven't even started talking about is the catastrophic health expenditures that households are witnessing. Ayushman Bharat only covers bottom 40% of the population. But health expenditure is a big component for impoverishment of households. If you go all the way for every class of households, and that is largely on account of not having proper insurance, private care being expensive, etc. So I think the health component is also somewhere where we can think of making things easier. So perhaps expand Ayushman Plus for at least the pandemic related expenditure. In hospitalization is very expensive, and the poor need that respite. So health is essential right now. Make that a part of the consumption support.
One thing
But
that
the
you
other
talked
broad
about
thing
is
which I
basically,
want to reiterate once more, is UBI is not going to work. Everyone, I'm hearing more and more doctors and people, and unfortunately several economists also say that cash. You see, cash, some amount of cash at the bottom will work because it helps buy some essentials. But largely cash in hand, UBI type, is only going to get diverted into precautionary savings. People don't consume. Private consumption is not going to rise till you have this level of uncertainty in the economy. And that is why we say that when private consumption can't increase, it's the government's job to spend. You raise the, you do the spending. Yeah, please go ahead.
Yeah, Smita, please go ahead.
Sorry, just one intervention, because you spoke about Ayushman Bharat, and I was seeing this report in India Today, which actually through RTI petitions and stuff found out that for a population of more than 11 crores, Bihar saw only 19 people avail treatment under Ayushman Bharat. In Uttar Pradesh, Jharkhand, the figure stands at 875 and 1419. So I am not really sure that even expanding it to Ayushman Bharat Plus is what we are looking at as a possible solution. And just a quick final question. How important and challenging will it be to perhaps do a proper data study of the adverse cases in people who have received both doses of vaccine. I mean, there is a lot of worry about, and rightly so, about vaccine hesitancy. I've been fully vaccinated with a vaccine which is still not giving me a vaccine passport, because I don't know when will Covaxin actually publish data. But there are several channels on Telegram that are talking about adverse cases, death cases. How will it be easy, difficult, challenging, important to take a look at the study of post double shots data on death and adversities?
That's a very important point, Smita. And in fact, just yesterday the report came out. I think, the dependence, because our own data systems are so lagging, particularly as far as the pandemic is concerned, that almost all our knowledge of the virus and the treatments are really a reflection of what is the research saying from the OECD countries. Right? So we depend on the AstraZeneca's efficacy, and we depend on the AstraZeneca's, how does it curb hospitalization or, the breakthrough infections, etc. All of that data is really coming from some other country. And I think that is the core, that is the biggest problem. In fact, Calgary yesterday said they had 2 deaths, and one was fully immunized AstraZeneca candidate. Right? So now, of course, it is 2 people. Now, I mean, what can you make out from something so small? But I think it is on account of the fact that we are not systematically collecting or disseminating. It's taking very long. Right? And even as far as plasma therapy, we made a very big deal out of plasma therapy. Several states have initiated, and they've set up plasma banks. And people have been running helter-skelter, trying to tap into that bank and etc. While we, an ICMR study was available in September, which said it is not effective. We waited 7 months for the global literature and the global data to then tell us that plasma does not work. So I think largely, Smita, I mean, I echo your frustration because we are not, we are waiting for the global scientific community to come up with data. We are, I think, truly, we are behind the curve. I think ICMR is under a lot of stress, but where is NHSRC? I don't know how many of you have heard of the institution. We need a lot of these public health institutions to come up and make sense of the data. Right? And even vaccination, we started vaccination 6 months back. Out of those 2 doses, how many people still got infected? How many were hospitalized? How severe was it? And what you are saying anecdotally is being heard everywhere now. But you see, till you statistically know what that number is, it always, we'll exaggerate it or we'll sort of play it. So yeah, no, I hear you. I hear you.
Mr. Chairman, there are 2 hands I see. Can you quickly do them so that Shamika can then
Sure. Because who are these hands? I don't see them because
I see 2 hands, Kailash Kumar and
please.
Suchi Pandey. And
Suchi Pandey. Kailash Kumar, let's start with Kailash Kumar first.
Okay, sir. Good evening, sir. Good evening, sir. And thank you, ma'am, and the organizing team, this webinar. I have 2 questions. The first question is, what is the economic cost? I consider the pseudo cost is being considered as far as data collection, like economic trigger is there, but what is the social and psychological and other factors which come into picture which affect the economic cost as well? So I'm thinking about that point. And the second question is regarding the trial system. Because trial system is very old concept, but India is not becoming a barrier to restrict the pandemic, rather becoming a link to become a chain. So I think why trial system is not working, as far as governance point of view. So I have 2 questions, sir. Please, thank you very much.
I'll take the other question also from Suchi Pandey, so she can reply together.
Good evening to everyone. This is Shuchi Pandey. My question to ma'am was actually the COVID-19 has impacted too much on the economy, right? And it has impacted too badly that it is not only affecting the economy, it is also affecting the people's health and everything. We are on a phase where people have started vaccinating themselves, but vaccination is also not done properly. Moreover, the 50% of the population, I think the children below the age of 18 are also not getting, we are not getting the data even over that thing, right? That what we are going to do with them, right? To overcome from the COVID-19, because the second wave included the children of 12 to 18 years also, right? So we are also not having the solution for that, right? And the last question to ma'am is that according to you, according to your calculations and effect on the economy of the COVID-19, how long will it take, approximate, that how long will it take to overcome from this COVID-19 and get on to our normal routine and normal workouts, right? Because we all are frustrated from that. Even attending these webinars is also a very
Good
bad
point.
thing to us, right? So my question is that a concern about, even I have 2 kids, right? And I have heard that in the second wave, many of the 12 to 18-year kids have infected, right, from this COVID-19.
Let her
And we are
reply
not
now. I
even-
think Panditji, you
Yes.
have asked long. Let her reply now.
Trial is there. Trial is there. I'm hearing every day, even in the newspapers also, that 80% trial is there with the Covishield and the Covaxin also. But we are not very sure that till what date we will get this vaccination for this 12 to 18-year kids, and even what will happen with the below 12 years kids, right? So that is also being concerned, because they're working from the online. Online surface will not be a permanent surface. Right?
Okay, Shuchiji, I think
I think let
Ask
her
the
answer
question.
it.
Yeah.
That's, you're not becoming
Yes.
a paragraph. Just be a question only. Let Dr. Ravi reply to you.
We
Yes.
all feel what you are feeling. We don't, we want our normal lives back. I completely understand what you're saying. But let me also be very honest with you, right? Let me be very honest. And I said this in last April, and at that point, many people were not happy. I said it'll take at least 3 years for us to get out of this. Now, 3 years was, we knew nothing about variants and variants becoming what they have, Delta plus, etc. But just knowing that, look, we have this population vaccination, and a certain minimum threshold will require X percentage of the population to be vaccinated, means that, logistically it will take time, right? So let's be prepared and know that this is the new normal. There is no excuse for not wearing a mask. There is no excuse for throwing caution to the wind and, abandoning social distancing, etc. So I think we are in this, all of us together. So we will have to abide by some of those disciplinary sort of practices. We'll have to bind ourselves down. But Suchi, the trials are there. We don't know the results of the trial. And before that happens, I doubt if vaccines will be made available to children. But the literature, I mean, just yesterday, we saw the AIMS seroprevalence survey, which basically said, children were likely to carry antibodies the same as adults, which means children are also infected. So number one, it is not that children don't get infected. They are infected, but they are asymptomatic, right? They don't fall sick. And that is just because children have better immunity. The virus cannot attack them and their immune system the way it will attack for older people. So I think children in that sense are better off. But just on that account, I think it will be some time. Now, of course, Pfizer in the US, they have opened it to kids, and I think, they are opening it. But going back to Kalash's question, Kalash, psychological cost is what Suchi just said. This fatigue, and we have a paper coming out, and I really, this is maybe a good time to pitch next week on COVID fatigue and what is the role of media in such a situation. We have been cursing the government. We curse each other. We curse our neighbor. Nobody's wearing masks. But what about the media? Have they been covering COVID? Or are we all collectively equally distracted? I think, evidence is supporting that every part of the economy does suffer from COVID fatigue. But I think there are roles. The government has a role it cannot abandon. It cannot say there is COVID fatigue. Similarly, we believe the media cannot say we have COVID fatigue. Therefore, we will not cover media. And I think people also, we say, therefore, wear masks and social distancing, etc. But the larger psychology cost, mental health is a very big problem, Kalash. I don't think we are going to see serious problems with productivity on many sectors. And remember, sectors like travel, tourism, they are completely under. So actually, there is a lot of loss of livelihood as well. There is a lot of livelihood getting lost in the informal sector, which we aren't able to capture very well either. All of this is likely to lead to enormous long-term psychological and not just psychological, I think real costs, right? Think of children. Think of children who have not seen their peers. The education is, online. These are all likely to have. In fact, there is a very nice survey which looked at under 6 standards, so primary school children, and they showed real decline in cognitive capability, math skills, writing skills, etc. So we should never underplay by bunching them together as either psychology or social, etc. These are long-term human capital costs that our economy is incurring every additional day that this virus is with us and we are not able to go about is an added day of added costs. So I think we have to be mindful of that. Suchi, Smita, one question on Bihar. Smita, just because they are not filing Ayushman Bharat claim does not mean that everybody who is getting COVID is there for above 40%. There might be, you see, in India, a lot of deaths are domiciliary deaths. People are dying in their homes. They don't even know why. 2 lakh children die every year for many, many years, and we don't talk about it because domiciliary death, meaning people dying in the house without death registration, is the reality of our public health system. So in Bihar, if 19 people or 200 people are filing claims, it does not mean that the coverage, that Ayushman Bharat will not, is not effective. I think they have to really go out and get people that, look, if you had COVID and you availed any kind of hospital, go file claim. At least you'll get some, recover those costs. So I think the insurance is tricky in any case. If you are not paying the premium, you don't even know that you are insured. So filing claims, the support system has to be far more widespread than just saying, let's cover 20% more people.
Thank you, Dr. Ravi, for that marvelously educative and analytical lecture. We expected nothing less. What's come out is that there is a macro picture which is more or less known to all those who follow it. And of course, there is the micro picture with its regional disparities, with its regional variations, class variations, the rural-urban divides, and therefore its impact or on analysis or what policy should be. And that has, I think, come out extremely well. And I thank the audience also for the response that they've put into the questions that they've asked. And I now hand over to Shakti Sinha to do whatever needs to be done now.
On our behalf, our Joint Director, Dr. Dholakia, who's also the Head of Department of Political Science at MS University, he would do the honors in thanking all of you. Dr. Dholakia, over to you.
Thank you, Shakti sir. It was indeed a thought-provoking lecture. And most importantly, the plea that Dr. Ravi made for an integrated policy-making approach and database policy analysis would go a long way for think tank like ours. As he rightly said, the analysis and interpretation of COVID has exposed the gaps in our data collection, data dissemination, and data interpretation activities. So certainly, I think there is a lot more to do based on what CS suggested today. And in this respect, we would definitely bank upon her expertise in future to guide institutions like ours so that these gaps in our data collection and data interpretation can be bridged. Very sincere thanks to Dr. Ravi for sparing her time and sharing her stimulating ideas with us at this very opportune moment when, as a society, we are fighting this biggest challenge to our existence and our human security. Thanks are also due to Professor Dipankar Sen-Gupta for joining us as the moderator for this discussion, which sets off a series of lectures on economic policies and economic dimensions, not just with respect to COVID, but with respect to many other areas. So once again, on behalf of the Atal Bihari Vajpayee Institute of Policy Research and International Studies, on behalf of Sri Shakti Sinha, on my personal behalf and on behalf of the MS University of Baroda, I thank Dr. Ravi, Professor Sen-Gupta, and each and everybody present today who participated actively and enthusiastically in today's discussion. And we, of course, look forward to your participation in future programs and future activities of the Institute, for which we will keep you updated through email and WhatsApp. Thank you one and all, and look forward to seeing you again. Have a very nice day. Thank you.
Thank you. Nisha, could you send your invite? Email will reply to you. If you send it anybody else, please send it by email. We'll reply to you. Because now the chat will go away as soon as we log it out. Thank you.
Thank you.